Welcome to Chapter 18, Chronic Restrictive Pulmonary Disease. So, overview of pathophysiology, characterized by diminished lung volumes. Parenchymal lung disease, alveolar units are destroyed and replaced by fibrous tissue. So this is, example of this would be fibrosis or asbestosis. Lungs are unable to expand, so alveolar units collapse. Inflammation, fibrosis develops, and loss of alveolar space and impaired O2 diffusion happens. Impaired O2 diffusion is evidenced by decline in arterial O2 saturation as seen by a pulse oximeter. You see arterial or blood saturation rates of less than 90%. So abnormal mechanical ventilatory function. Airflow rates are reduced in proportion to the reduction in lung volumes. More energy is needed to breathe so that during exercise, the lungs require a greater percentage of cardiac output, and so active muscles can suffer. This leads to greater lactic acid production and also hydrogen production, so increased acidity of the blood, which can make exercise and even physical activity pretty uncomfortable. So secondary hemodynamic and cardiac dysfunction. Damage to the pulmonary vascular bed increases pulmonary vascular resistance. So that leads to what? Well, that leads to higher pressures on the right side of the heart. Remember, the right side of the heart is the side of the heart that pumps blood to the lungs. And if you deal with chronically high pressures on the right side, that can lead to right side heart failure. And so you can get secondary pulmonary hypertension, right side heart strain, and lower exercise stroke volume. And so with right side heart failure, you get pretty much edema in the periphery or like swollen legs because fluid backs up from the pump. And yeah, so that's not a good deal. And as the lungs get stiffer, the lungs surround the heart, so that can also lead to difficulties with the heart expanding to fill with blood. So you have quite a few factors that can affect your health related to chronic restrictive pulmonary disease. So effects on the exercise response: reduced exercise tolerance and exertional dyspnea. Rapid shallow breathing typically occurs, an increase in minute ventilation due to restricted tidal volume. Now, you have diffusion of carbon monoxide and alveolar ventilation. So what is that? Well, the lungs diffusion capacity for carbon monoxide is used as a measure of lung function. Carbon monoxide transfers to the blood pretty quickly, and they know how fast it should transfer in, so they use that diffusion rate as a measure of lung function. And so if you have a lower diffusion rate, you have some type of lung issue. And, well, with alveolar ventilation, that's alveolar volume and ventilation. So lung function can be reduced by the following: a hindrance in alveolar wall, so for example in fibrosis, decrease in total lung area that you might see in emphysema, uneven spread of air in the lungs with emphysema as well, cardiac insufficiency, hemoglobin decrease in the blood, and pulmonary hypertension. So effects of exercise training. What you get with exercise training is typically an improved submax endurance. Max O2 consumption increases. Ventilatory endurance and ventilatory perfusion matching is better after exercise. So you also get reduced blood flow requirements. You get reduced lactic acidosis or decreased hydrogen content within the blood and acidity of the blood. You also get decreased fear associated with dyspnea. So with proper exercise training, including breathing techniques, you get this perception that exercise isn't that tough and something that a person can do with chronic restrictive pulmonary disease. So management medications: corticosteroids are given to reduce inflammation and retard disease progression. However, chronic drug therapy can lead to obesity, hypertension, hypoglycemia, loss of bone mineral density, so that increase in osteoporosis, and muscle atrophy. Supplemental oxygen therapy is necessary, so you monitor blood oxygen saturation, blood O2 saturation, and if that drops below 90%, you want to give supplemental oxygen. And also general health maintenance, typically weight control, blood pressure control, with proper nutrition, control exposure to tobacco and environmental irritants, and vaccinate regularly against respiratory pathogens because you have damage to the lungs, and the lungs are exposed to outside air. So when you have this damage, you get this increased risk of infection. And the weight control, you can get chronic restrictive pulmonary disease because of obesity. You have so much adipose tissue, so much fat, that restricts the expansion of the lungs. So recommendations for exercise testing. The goal is to define disability due to pulmonary dysfunction, detect coexistent factors that aggravate the disability, and monitor progression of impairment and response to therapy. So you want to see how the test, how your exercise program or therapy is going with these patients and over time. And so you'll continually do some tests just to make sure that everything's on the right track. So cycle ergometer or treadmill with resistance, with a resistance-free warm-up. So, excuse me. You want to use an EKG and pulse oximeter. So if O2 saturation drops below 90%, you want to give supplemental oxygen. And you also have meticulous attention to detail. This will help reduce anxiety in the patients or subjects. And so the best way to do this is to practice the procedures. So if you are in an area where you don't commonly see a lot of people with a certain pulmonary disease, and you're doing a new test, you make sure you practice that test because they're uncomfortable enough having to do any type of physical exertion that may cause some shortness of breath. And so make sure you practice the procedures. Recommendations for exercise testing, not recommended. You don't have to measure VO2 max or VO2 peak necessarily in these tests. You can, though. So endpoints apart from normal, things that you want to measure, max ventilations, VO2 peak, and also lactate ventilatory threshold. You must use an EKG, you must measure blood pressure, and you must measure O2 saturation levels during the test. Testing in the morning or early afternoon is preferable because things tend to get worse later on in the day. Meds should be taken as usual, and spirometry and max voluntary ventilation are helpful in defining ventilatory limitations. Recommendations for exercise programming. You want to go through and teach proper breathing techniques before you start the program. Exercise should be practical and enjoyable if it's going to be sustained, and that applies to a lot of exercise programs. But, these people don't like to be short of breath because they're typically that way all the time. So try to find something that they may enjoy, either love the most or hate the least. Walking with arm or leg exercises added during sedentary activities. Initial intense training period, 20 to 30 minutes a day, 5 days a week for 6 to 8 weeks, followed by 3 days a week. Training can be divided into segments with follow-up assessments. So here it is broken down. Aerobic training, 3 to 5 days per week. Monitor shortness of breath. 20 to 60-minute sessions can be broken up into shorter sessions. 11 to 13 on the rate of perceived exertion scale. 1 to 2 sessions per day, and emphasize duration over intensity. And for strength, you want to do 2 to 3 days per week, high reps and low resistance.